Now what is the inguinal region? We know anterior superior iliac spine and the symphysis pubis, and there is a pubic race, pubic tubercle we know in the hip bone, or you will be knowing. So it is nothing but the part of the anterior abdominal wall below the level of anterior superior iliac spine. That means if we join to anterior superior iliac spine, then from then onwards on the lower, that means the lower abdomen, the anterior abdominal wall is the region where we call it as a inguinal region. This lower abdomen, this inguinal region is the anterior abdominal wall or the lower part of the anterior abdominal wall or the inguinal region has got a peculiarity. Peculiarity, that means in the first peculiarity that is common in the anterior wall, there is no, yes, very good, there is no deep fascia. So abdomen can expand, it can again come to its own original position. So there is continuous up and down movements or forward and backward movement of the abdomen. So that is during that means the abdomino-respiratory type of respiration we have. So that is an indication. So for that purpose, there is no deep fascia. But there are some, but it covers the abdomen. Abdomen has got so many viscera. So that part should be, there is a mechanism by which the abdomen is taut reflexly, so that it can prevent the inner viscera. Now the anterior abdominal wall, there are three muscles from superficial to deep. They are external oblique, deep to that there is internal oblique, and deep to that there is transversus abdominis. And in the medial side we are seeing there is one straight muscle, that is the rectus abdominis. So these three muscles, external oblique, internal oblique and transversus abdominis, ultimately when they are approaching from lateral to medial, what happens? The muscular component we will not get. We will see it becomes aponeurotic, membrane-like, tendon-like. Similarly, this is external oblique aponeurosis and internal oblique aponeurosis and the transversus abdominis. It also becomes aponeurotic, and ultimately they forms the sheath for this muscle, that is a rectus sheath. But we are concerned with the inguinal region, and that region also where we will get the external oblique, internal oblique, transversus abdominis muscle, but we will get gradually, we will see lateral part is muscular, but the medially, as we approach medially, external oblique becomes external oblique aponeurosis. Similarly, the internal oblique, it is taking origin from lateral side. I will discuss. But this internal oblique and the transversus abdominis, when it is taking origin from a ligament that is called inguinal ligament, I will discuss, I will tell you what is inguinal ligament. During this, when they are originating, that is muscular, but when they are approaching medially, becomes aponeurotic. And this internal oblique and transversus abdominis, suppose this is internal oblique and this is transversus abdominis, they get fused medially and forms a common tendon which is called conjoint tendon. Okay. And behind this transversus abdominis, we will get another layer, that is a fascia, which is called fascia transversalis. And if we go deep to that fascia transversalis, we will enter into extraperitoneal fatty tissue, and ultimately we will enter into the peritoneal cavity, and we will come across with the parietal peritoneum. That means within the abdomen, there is a covering, one visceral covering like pleural cavity. It is intimately attached with the viscera, then it becomes reflected and becomes parietal. So it forms a bladder like structure. So that is the and within that we will get the peritoneal cavity. So external oblique, then internal oblique, then transversus abdominis, then we will get the fascia transversalis, then we will get the extraperitoneal fatty tissue, then we will come across the parietal peritoneum. So if we stab the abdomen, so we will come across with the skin, then we will superficial fascia, then we have to stab the external oblique, then we have to stab the internal oblique, then transversus abdominis, then fascia transversalis, then we will get extraperitoneal fatty tissue, parietal peritoneum, and ultimately the knife will enter into the peritoneal cavity or abdominal cavity, abdominopelvic cavity, abdomen, and this is lower part is the pelvis. So there is another peculiarity in the lower abdomen, that is the inguinal region, that is about the superficial fascia. Here the superficial fascia is splitted into two parts. We know we have seen the superficial fascia in our body. We have seen the deep fascia covering the muscles. We have seen, but we have seen that superficial fascia has got only one layer. But in the inguinal region, it splits into two layers. One is outside layer, one is inside layer. The outside layer is fatty layer, and inside layer, the inside one is membranous layer. This outside layer is the fatty layer of Camper. Who had discovered this one? And the inner membranous layer of Scarpa. So when we will, suppose I am giving an incision from anterior superior iliac spine up to the midline, and from the midline up to the symphysis pubis, I am giving an incision. So I will reflect the skin. When I will reflect the skin, I will get superficial fascia, and here we will get, within the superficial fascia there are some veins or vessels, superficial vessels. Okay, like one is around this anterior superior iliac spine. One is towards the abdomen and one is towards the symphysis pubis. So, this one is circumflex, this is the circumflex iliac branch, one is superficial epigastric vessels and another is superficial external pudendal. Okay. So, we will get some nerves also. Now, when we will retract the skin, we will get the superficial fascia, that is the superficial layer, that means the layer of the fatty layer of camper. Fatty layer of camper. Again we will cut that layer and we will retract, we will get the fatty layer of membranous layer of scarpa. Again we will remove that one. When we will remove that one, then we will see, that is this inguinal region, there is a muscle. This is taking origin from above, from lower 8 ribs. There is conjoint origin. There is serratus anterior muscle, we know, for upper 8 ribs and lower 8 ribs for external oblique muscle. So, these muscle fibers, they will travel like this. So, like you are putting your hands in the pocket. Okay. So, this is the direction of that muscle and we can see it in, now we can see that muscle. Here we can see that muscle, that is the external oblique muscle and it is becoming, we can see, now we can see that muscle. Okay. We can see this is taking origin from the lower 8 ribs. Okay. And the fibers are directed downwards, forwards and medially. Okay. And we are concerned, what is the inguinal region? We know this is the anterior superior iliac spine, this is the anterior superior iliac spine. So, if we join these two lines, so from this line onwards or downwards, we get this region, this is the inguinal region. And here we can find this muscle is on the lateral side, this is muscular. As we go medially, this becomes white, that means it is membranous, that becomes, that is aponeurosis. And we can find an irregular F, the outline, the junction between the muscle and the aponeurosis is F-like, irregular F-like. Okay. So, we can find the direction. Okay. They are actually analogous with, we know there are some respiratory muscles, external intercostal, internal intercostal, intercostal intimi. So, this external oblique, internal oblique, transversus abdominis, they are just analogous. Even we are getting in between internal intercostal and intercostal intimi, there we are getting the neurovascular planes. Here also in between the transversus abdominis and the internal oblique, we will get the nerves and vessels, and they are important, they are ilioinguinal and iliohypogastric nerve. Okay. They are coming from the L1 segment of the spinal cord. So, now we can appreciate this muscle and also we can appreciate another thing, this muscle ultimately becomes folded in between anterior superior iliac spine and this is the pubic tubercle. In between these two areas, this muscle itself becomes folded. like this and forms a ligament. This ligament is nothing but the inguinal ligament. Inguinal ligament. So, what is inguinal ligament? It is folded part, thickened part, lower part of the external oblique muscle or aponeurosis. Okay. And here also we can find a gap, a triangular gap, though it looks like a circular, but triangle is like this is one side, this is another side, this is another side. So, we can get another one opening in this muscle. Okay. Nature has purposefully made this opening because there was a journey of the gonads in embryonic period. Actually, gonads develops in the lower thoracic segments and upper lumbar segments of the abdomen, and ultimately there is a journey, and the gonads are being dragged by some elements which are called the gubernaculum. Okay, gonads were in the posterior abdominal wall. They are being dragged. So, by the gubernaculum. Okay, but there is a controversy whether it drags or not. Okay, whether gubernaculum, what is the process of the journey of the gonads. So, in case of male, it is the testis, and in case of the female, that is the ovary. So, gubernaculum actually, suppose it drags those gonads, and ultimately from the posterior abdominal wall it goes through this anterior abdominal wall and it exits through this opening, and ultimately in case of male it enters into the scrotal sac and ends at the bottom of the scrotal sac. There it ends the journey, and it is that testis gets its final destiny, and the gubernaculum remnants becomes the scrotal ligament. Okay. So, this is important because when we will dissect our body, we will find this opening, and also we will find a cord which ends into the gonad. In case of male, the testis, and in case of female, ovary, but ovary do not descend through this tract. Okay. Okay. But the gubernaculum, okay, actually it is attached from the ovary to that uterus, and ultimately that gubernaculum moves through this pathway and ultimately enters into the labial swelling, that is the labia majora. So, as a whole it is called labioscrotal swelling. When it is developing, there is no differentiation between male and female. So, if that swelling was present in both sexes. So, that is called labioscrotal swelling. So, ultimately the gubernaculum which was dragging the ovary, it drags up to certain extent, and ultimately ovary gets its position in the ovarian fossa. But the gubernaculum is there. So, there is the gubernaculum from ovary to the uterus, that forms the ovarian ligament. From uterus to ultimately it passes through this tract, and ultimately it is attached to the labia majora. So, that part is called, from uterus to the labia majora, which traverses this tract, is called round ligament of the uterus. So, this is the pathway through which either testis or the round ligament testis along with testis and along with the other substances, you will know gradually, or and in case of female, the round ligament of the uterus, okay, will move. Okay. So, this is an opening, and this opening is triangular. It is the base. This is the pubic tubercle, this is the symphysis pubis. So, this forms the base, and it has got medial crus and lateral crus. Okay. And ultimately, the apex is here. So, this is 2.5 centimeter, okay, and this is 1.25 centimeter. Okay. So, this is the superficial inguinal ring opening. This is superficial inguinal ring. Similarly, we will get the deep ring, but we can come back to the original slide. Now, we can see here we have come across the external oblique muscle, and we have seen the inguinal ligament. Okay. Inguinal ligament becomes like this, and from here inguinal ligament we can get some other corollaries, that means derivatives. One derivative we can see, this forms the floor and it forms another ligament. This is called lacunar ligament, which has got base directed on this region and apex is directed towards the pubic tubercle. So, it is a triangular ligament. So, the same muscle, that same muscle aponeurosis, that means external oblique aponeurosis, ultimately forms this inguinal ligament, also it forms this lacunar ligament. Okay. So, this lacunar ligament is another thing we can find in this region, okay, and which has got apex and which has got base. Okay. So, and this lacunar ligament, the innermost lip, it is continued along we can this is continued as pectinate ligament. Okay, this is not visible here. This outer lip we can see, the inner lip is continued up to the iliopubic eminence. So, that part is called pectinate ligament. Pectinate ligament or pectinate ligament of copper. Okay. So, another thing we can find from this inguinal ligament, another part is reflected like this and up to the midline. This is called reflected part of the inguinal ligament. Okay. So, just have some idea. This inguinal ligament has its derivatives like lacunar ligament, pectinate ligament and reflected part of the inguinal ligament. And this reflected part, we can know this is the midline. In the midline, there is a wide fibrous structure which is called linea alba. So, it is continued up to the linea alba. Similarly, from other side, there we are getting the reflected part. So, it is continued to the other side. Okay. Next, when we will dissect the external oblique muscle. So, now we are getting the external oblique muscle, and here in the midline we are getting this rectus abdominis muscle. এই দেখো এটা ভুল করা আছে দেখো বুঝেছো এটা ভুল হয়েছে this is rectus abdominis okay forget it so this is the rectus abdominis muscle It is taking origin from the ribs and it is here, okay. So this is rectus muscle. So external oblique muscle is continued up to this area, okay, in the lower abdomen. So we will give an incision from here up to the lateral border of the rectus abdominis, and that incision is continued up to the symphysis pubis. So if we do the dissection like this, then we can remove the external oblique aponeurosis. Then we will get the internal oblique muscle. Internal oblique, how is it? How it looks like? Okay. Na dekhale to hobe na, we have to show you. Unless and until I show you the muscle, you will not have any impression. So let us have, this is the external oblique. Okay. Now here so we have removed this external oblique muscle. Okay. Here we can have some idea. The most outside, that is the external oblique muscle, and it is folded. Okay. Then it forms the inguinal ligament. Next is the internal oblique. Next is the transversus abdominis. Okay. And deep to that we will get the fascia transversalis. Horizontal section of the abdomen. Horizontally we are cutting the abdomen. So from outside we are getting external oblique muscle. This, when we are going medially, it becomes aponeurosis, aponeurotic. Okay. This is in front, this is behind. Okay. So from the front to behind, okay, we are getting external oblique, which becomes a membrane like, which is called external oblique aponeurosis, and within it we are getting one opening. Okay. This opening is called superficial inguinal ring. Okay. Similarly, deep to it we are getting internal oblique muscle. Okay. And deep to it we are getting transversus abdominis muscle. This internal oblique and transversus abdominis, actually they get fused medially, and they get fused medially and forms this tendon. Okay, this is called conjoint tendon. Clear? Is it clear or not? And deep to it we are getting fascia transversalis. The blue one is nothing but the fascia transversalis, and here within this blue line, that is fascia, within the fascia transversalis we are getting another opening, which is called deep inguinal ring. So from superficial inguinal ring to deep ring, or deep ring to superficial ring, we are getting a tract. We are getting a tract, and this is called inguinal canal. So what is superficial ring? It is an opening in the external oblique aponeurosis, which is just present just above the pubic crest. And what is internal deep inguinal ring? This is another opening. It is said that it is an opening, but it is not an opening. It is when actually the gonads are coming from posterior abdominal wall to anterior abdominal wall, they are actually dragging this fascia. Okay, so this fascia, this opening is the mouth of the fascia transversalis, which is being dragged by this give vernaculum. Similarly, what is superficial inguinal ring? This is nothing but this is the external oblique aponeurosis, which is been dragged by the gubernaculum. So there are two openings, that is, one is superficial ring, one is deep ring. So what is inguinal canal? Inguinal canal is the canal which is present in the lower abdominal wall from deep ring, deep inguinal ring to the superficial inguinal ring, and it is an oblique canal present. It is oblique canal. It is a musculo-aponeurotic canal because lateral part is muscular, medial part is aponeurotic. It is oblique canal, oblique musculo-aponeurotic canal, which is present parallel to the medial part of the inguinal ligament. Inguinal ligament is here, deep ring is here, superficial ring is here. So this is an oblique canal which is traversing from deep inguinal ring to the superficial inguinal ring. It is oblique canal, it is musculo-aponeurotic canal, and it is traversing parallel to the medial part of the inguinal ligament. So what is the extent? Its extent is from deep ring to the superficial ring. How it is formed? The anterior wall is formed. We can see this is the anterior wall. This is the posterior wall. The anterior wall is formed by this external oblique aponeurosis. Okay. The anterior wall is mainly formed by this external oblique aponeurosis. Posterior wall is formed mainly by this fascia transversalis. Can mainly bolam? Why mainly? Because we can see this in the lateral part, this internal oblique muscle also reinforces the anterior wall. Reinforces the anterior wall. This is the anterior wall. Anterior wall is reinforced by this internal oblique in the lateral part. Similarly, the posterior wall is also reinforced by this conjoint tendon, because this transversus abdominis, this internal oblique and transversus abdominis actually gets fused and it is continued as conjoint ligament, and it is going towards the posterior wall. So the posterior wall is being reinforced medially by this conjoint tendon. This internal oblique muscle and transversus abdominis muscle, they becomes aponeurotic medially. Here we are getting the muscle, and ultimately they are getting the aponeurosis gets fused and forms a common tendon, which is called the conjoint tendon. And medially we are getting the green one, that is the conjoint tendon. They have been contributed by internal oblique and transversus abdominis. So internal oblique is reinforcing the lateral part of the anterior abdominal wall, whereas this conjoint tendon is reinforcing the posterior wall. Okay, superficial inguinal ring. এখানে গোনাডস এখানে তৈরি হচ্ছে, ঠিক আছে, posterior abdominal wall এ gonads এখান থেকে মুভ করবে through, it will move through the deep ring, it will pass through this canal, inguinal canal, and ultimately it will reach the superficial ring and it will come down to its original position. Just about 7 months of intrauterine life, gonads actually, that means the testis actually remains here at the level of deep inguinal ring. at 9 months, it remains here. So from 7 to 9 months, it completes its journey through the inguinal canal. Okay. So at 7 months, it was at deep ring. This superficial ring and deep ring, they are all present in the anterior abdominal wall. You should have clear idea where it is present. Not in our face, not in any part of our body. They are present in the anterior abdominal wall. Where? At the deep ring is present at the fascia transversalis. Okay. And superficial ring is present in the external oblique aponeurosis. So, deep ring to superficial ring, this area is called the inguinal canal. So, inguinal canal is nothing. This is not a fictitious canal. Here we can find if we join these two opening, we are getting this canal. And it has got embryological importance, because through this canal, actually the testis or the round ligament of the ovary, they actually moves through. So along testis, what other structures? We know there are, actually when testis with the gubernaculum it is moving, we will get other structures. As a whole, it becomes a cord, which is called spermatic cord. Okay. So when testis will move through this inguinal canal and ultimately will reach to the scrotal sac, we will find there is a constituents which will form this cord, and this cord is called spermatic cord, and there are several constituents. So where the spermatic cord actually it starts from the upper pole of the testis and it will end in the deep inguinal ring, from where the other structures will take their own pathway. Like, what are the constituents? First is the vas deferens. What is vas deferens? This continuation of we know testis is there, then it is continued as epididymis. From epididymis, it is continued as vas. So it first remains posteromedial to the testis or epididymis, then from the upper pole, it goes up. And it goes throughout this superficial ring, deep ring, and ultimately it will end into the ejaculatory duct. So that is the vas deferens. So one of the most important constituent is the vas deferens. Then testicular artery. Testicular artery is coming from it is a branch from it is a lateral branch at the level of L3 vertebra. Okay, this is the lateral branch. So that is a gonadal branch. So in case of female, it is the ovarian artery, and in case of male, it is the testicular artery. So that testicular artery again enters through the deep ring and leaves the superficial ring and reaches the testis. Kothaya jabe? Testis. Then testicular veins. In the testis, there is a plexus of veins, which is called pampiniform plexus. The artery is going towards the testis, and from there, what will come out? The veins will come out. So first they will form a plexus of veins. They are called pampiniform plexus within the testis. Around the testis, that means in front, behind, we will get that plexus or network of veins. From this pampiniform plexus, 12 to 15 veins will start, and they will reach the superficial ring. And when it is there approaching the superficial ring, these 12 to 15 veins joins to form 4 veins. And these 4 veins actually moves through this superficial ring to the deep ring. And when they are approaching the deep ring, these 4 veins becomes 2 veins. They join into and they form 2 veins. And these 2 veins from the deep ring, they go inside the abdomen, and ultimately at different level they joins to form a single testicular vein. Okay. Then the right testicular vein, remember, it drains directly into the inferior vena cava. Whereas the left testicular vein drains into the left renal vein at right angle. Left testicular vein remains at a higher level. Okay. Because left testicular vein drains into the left renal vein, and whereas the right testicular vein drains directly into the inferior vena cava. So the length of the left testicular vein is more than the right. Again, the left testicular vein passes behind the pelvic colon. It is moving from here, it is moving to the pelvis. There is a pelvic colon and it passes behind the pelvic colon and ultimately drains into the left testicular vein, left renal vein. And this left pelvic colon is always almost always loaded with the fecal matter. So it has to pump more to enter into the left renal vein. Okay. So and it is directly at a right angle, it is draining into the left renal vein, whereas the right vein is obliquely, it is draining into the inferior vena cava. On the right side, it is draining like this obliquely into the inferior vena cava at a lower level. So these 3 factors causes varicosity of the left testicular vein, very common. It is varicosity on left testicular vein is very common than the right because of these 3 factors, because the length is more, passes behind the pelvic colon, and it drains directly into the, and it drains at a right angle. তোমাকে যদি পাহাড়ে উঠতে বলা হয়, তোমাকে যদি স্লোপ দেওয়া হয়, তুমি কি আস্তে আস্তে ধীরে সুস্থে উঠবে? রাইট অ্যাঙ্গেলে যদি উঠতে বলে, what is varicosity? It is nothing but the dilatation, elongation and tortuosity. So dilatation, the veins become dilated, elongated and tortuous, and so it becomes, we can feel there is a swelling in the scrotal swelling. You will get in the surgery, in the clinics of the surgery, the patient has come with swelling of the scrotal swelling. There we can find, so we can examine after the clinical examination, we can detect that this is the varicosity. Okay. So testicular arteries, testicular vein. Then other constituents, the sympathetic nerves will move. Okay. Sympathetic, the testicular nerve, actually sympathetic, they are coming from the T10 segments of the spinal cord, and it reaches the testis. So the same segment is supplied by the umbilicus. So testicular pain will get referred around the umbilicus because same segmental supply. It is also been supplied by the T10 segment, and the testis is supplied by the T10 segment, and also the appendix also been supplied by the T10 segments. So, pain around the umbilical, see, because pain in the appendix also starts actually from the umbilical region, ultimately settles to the right iliac fossa. You will know what is iliac fossa later on. Then other constituents of the spermatic cord, lymphatics are there. Okay, lymphatics are there. Lymphatics, so lymphatics from the testes, they ultimately drain into the pre and para-aortic group of lymph nodes. So, in filaria, we can get the scrotal swelling because there is obstruction of those lymphatics. Okay. So, we will find within the spermatic cord, and spermatic cord is covered with 3 layers. One is external spermatic fascia, internal spermatic fascia, and in between there is a cremasteric fascia. Outside is external spermatic fascia, inside is internal spermatic fascia, and in between we are getting the cremasteric fascia. It's a common sense, you can answer now. External spermatic fascia is being contributed by this external oblique muscle. Internal spermatic fascia is nothing but the continuation of the fascia transversalis, and cremasteric fascia, they are being contributed by this internal oblique and transversus abdominis, they forms actually the cremasteric fascia. Why they are getting these coverings? Because during its journey, the gonad is taking the coverings from fascia transversalis, from these cremaster muscles, that means internal oblique and transversus abdominis, and ultimately it is taking the outer covering from the external oblique muscle. So, external spermatic fascia is nothing but external oblique aponeurosis. Internal spermatic fascia is nothing but the fascia transversalis, and cremasteric fascia is being contributed by both internal oblique and এটা মোটামুটি এগুলো তো বুঝিয়ে দিলাম, এইটুকু বুঝতে পারলেই বিরাট বলো। এইবার now we are getting the anterior wall of the canal, there is a posterior wall, and floor is by, this is the external oblique, and it is becoming folded, and it forms the floor of the canal. Okay. Roof, we are getting this internal oblique and transversus abdominis are getting apposed, and it is continued as a conjoint tendon. So, these two muscles forms the roof. Floor is contributed by external oblique aponeurosis. Roof is formed by this internal oblique and transversus abdominis, continued. Anterior wall, that is the external oblique aponeurosis. Posterior wall, fascia transversalis. Now, there is a ওইটাই এবার ওই ইনফিরিয়র এপিগ্যাস্ট্রিকটাতে এলে এবার ওটাতেই বুঝে যাবে, বুঝলে? ওই যে ছবিটা ছিল ইন্টারনাল, এই যে এটা, this is. Now we are getting this opening is within the fascia transversalis, that is, when we will get this opening, when we will remove the external oblique muscle, when we will remove the internal oblique and transversus abdominis muscle, okay, then we will get this opening within the fascia transversalis, and that opening is deep inguinal ring. Now here, just below and medially, we can see one artery is moving deep to the fascia transversalis, and this artery is known as ইনফিরিয়ার এপিগ্যাস্ট্রিক আর্টারি। এটা কি আকাশ থেকে এলো, হঠাৎ উড়ে এলো, মানে কোথা থেকে এলো? ইট ইজ কামিং ফ্রম ফেসিয়াল আর্টারি, ইট ইজ কামিং ফ্রম ব্রেকিয়াল আর্টারি। Suddenly we can see when we are dissecting, we will see the fascia transversalis and deep to the fascia transversalis, this artery will shine. This is the inferior epigastric artery. It is coming from aorta, abdominal aorta divides into common iliac. This common iliac is again divided into external iliac and internal iliac. From the external iliac, this artery will come out. This external iliac is again continued as femoral when it crosses the inguinal ligament. Okay. So, this artery is very important, is a very important guide for us to detect the deep ring. This lateral to it, we will get this deep ring. Okay. And what is other importance? We know there are some weak points in the abdomen. What are those weak points? The superficial ring, there is opening. If there is an opening, there is a weak point. Superficial ring, similarly the deep ring, that is also a weak point. So from this is the anterior abdominal wall, both the superficial and deep ring, they are in the anterior abdominal wall. So they are the vulnerable points, because there is always a chance of protrusion of any viscus or viscera through these openings, and this protrusion is called hernia. So this, when a viscus is coming out and passes through this deep inguinal ring, and ultimately it passes through the superficial ring. Okay, it can happen, or it can come directly from this area. Okay, that if suppose this fascia transversalis is becoming very thin and thin in old age, or the external oblique and internal oblique, transversus abdominis, they are becoming very thin, then what will happen? Directly this viscus or viscera will come out from this area, and it will enter into the superficial ring. So any herniation through this inguinal region is called inguinal hernia. So they may come out through the deep ring, and they can pass through the inguinal canal, it can come out, or they can come directly from the anterior abdominal wall, and they ultimately it will pass the medial part of the inguinal canal, and it will come out through the inguinal ring, superficial ring. So when it is coming from this deep ring, it is called indirect inguinal hernia. When it is coming medial to the deep ring, that is from this area, this is called direct inguinal hernia. Direct inguinal hernia. And we can also see a triangle here. Okay, so direct hernia is through this triangle. This triangle is called, we can see, one side is formed by the inguinal ligament, one side is formed by the lateral border of the rectus abdominis, and another side is formed by the inferior epigastric artery. So this triangle is called Hassel's back triangle. When hernia is protruding through this Hasselback's triangle, it is called direct hernia. When it is passing direct inguinal hernia, when it is passing through the ring and it is traversing the inguinal canal, it is called indirect inguinal hernia. And similarly, we will get another, we can see a dot line. What is this dot line? This is nothing but obliterated umbilical. There are two obliterated umbilical artery, one single vein, umbilical vein, that is left umbilical vein. In the body there is only the left umbilical vein and two umbilical artery. This obliterated umbilical artery is also visible at this area. Okay, when we will remove the anterior abdominal wall, we will see this obliterated umbilical artery. After obliteration, it forms a ligament which is called medial umbilical ligament. So, when this hernia is coming through, is lateral to this obliterated artery but medial to the inferior epigastric artery, that means this area, this is called lateral direct hernia. When it is passing through this area, that means medial to the obliterated umbilical artery but lateral to the lateral border of the rectus abdominis, this area, this is called medial direct inguinal hernia. So, inguinal hernia has got indirect and direct. Direct has lateral direct and medial direct. এটুকু ঢুকেছে তো? ঢুকেছে তো? ব্যাস, that's all. Now, another content of the spermatic cord which do not passes through this deep ring, okay, but it joins with the medial part of the inguinal canal. There is only one structure, that is ilio-inguinal nerve. I was saying in between transversus abdominis and internal oblique, there are two nerves. One is ilio-hypogastric nerve, one is ilio-inguinal nerve. That's ilio-inguinal nerve is piercing this internal oblique. Okay, it remains in between internal oblique and transversus abdominis. Then at one moment it pierces the internal oblique and it comes out and it joins with the canal. Okay, inguinal, it enters into the inguinal canal. That is ilio-inguinal nerve. Both this ilio-inguinal nerve and ilio-hypogastric nerve, they are coming from the L1 segment of the spinal cord. So, where we will get this ilio-inguinal nerve? If we go 2.5 centimeter in front and 2.5 centimeter below the level of anterior superior iliac spine, then at this point this ilio-inguinal nerve will pierces the internal oblique muscle and it will continue because if we remove the external oblique, if we remove the skin and superficial fascia, we can see the superficial ring along with the cord. If we remove the external oblique muscle, then we will get the major part of the spermatic cord. Here we will see that nerve is piercing the internal oblique muscle and joining with that spermatic cord. So, remember, this is the only content, that is the ilio-inguinal nerve. Okay, it supplies, it traverses, it do not passes through the deep ring, it joins with the medial part of the inguinal canal and ultimately comes out through the superficial inguinal ring. Femoral hernia. So, pubic tubercle is the determining point by which we can detect whether it is inguinal hernia or femoral hernia. আর আছে? কাভারিংস গুলো এখন আর বইয়ে কি পারবো, হবে না। এই দেখো, within the scrotum you can see the skin, and here we are getting external oblique muscle which becomes external spermatic fascia, okay, and in between there is the superficial fascia, there is a fascia of Scarpa which forms the dartos muscle, and this is external spermatic fascia is nothing but the continuation of the external oblique muscle. Then internal oblique and transversus abdominis muscle, they forms the cremasteric fascia, the red one, and this fascia transversalis, the blue one, forms the internal spermatic fascia. External cremasteric and internal spermatic fascia. So as a whole, they forms the covering of this spermatic cord. দেখো এই ছবিতে কিন্তু ক্লিয়ার বুঝিয়ে দিচ্ছে, the external oblique forms the external spermatic fascia, internal oblique and transversus abdominis they joins to form the cremasteric fascia, and fascia transversalis is continued as internal spermatic fascia, and they covers the whole spermatic cord. So in case of, and what we can find, this through the abdomen, this is the deep ring, this is the superficial ring, a part of the viscous along with the peritoneum is coming out. This is the hernia, okay, this is the hernia which is coming, and it is ultimately, if it reaches the testis, it is called as complete inguinal hernia. Inguinal hernia, the definition should be like that: indirect, complete inguinal hernia. This should be the complete one. This should be complete one. And if it is direct, and if it reaches up to the testis, direct, complete inguinal hernia, or lateral direct. There are symptoms. The position of the deep ring is just ½ inch above the mid-inguinal ligament, mid-inguinal point. That means in between, the point in between, that the midpoint is the meeting point of anterior superior iliac spine and the pubic tubercle. That is the inguinal ligament, okay. So ½ inch above that one, if we press, if we reduce the hernia and if we press, then that is the position of the deep ring, and we ask the patient to cough, and if we can feel that hernia tries to protrude, we can feel that it tries to come out, so that becomes direct hernia. Here if we press, after reduction of the hernia, if we press and if we ask the patient cough to the other side, then we can feel it is coming. If the hernia tries to come out through that area, that is the indirect, it is coming. And if we press it, but there is no use because it is coming out, so it is medial to it, okay, that is the direct inguinal hernia.